Welcome back to HIV Update, Adherence Advances with New ART Formulations, presented by the University of South Florida at ID Care Live. Today's final session is titled Innovations in Antiretroviral Therapy Formulations. My name is Dr. Paul Sachs, and I'm Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Activities on ID Care Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Linda Spooner. She's Professor of Pharmacy Practice at Massachusetts College of Pharmacy and Health Sciences. Linda, thank you very much for joining us today, and let's get started.
Great. Thank you, Paul. I appreciate the introduction. I have also listed our disclosures here on this slide for your information. But we're going to get right into a case presentation of Janelle. And what I want you to do is keep Janelle in mind while we go through the presentations today so that we can revisit her at the end and talk a little bit more about what antiretroviral therapy we would choose for her and her unique considerations. So Janelle is a 31-year-old woman who presents to the HIV clinic for initiation of antiretroviral therapy. She was diagnosed 4 weeks ago by her new primary care provider, who performed an HIV test as part of her lab work for entry into care. Her past medical history is significant for depression, migraine headaches, and seizure disorder. Her social history: she's sexually active with a boyfriend, she uses alcohol socially, and she works the night shift 5 times per week as a toll collector. She has no known drug allergies, and her current medications include ibuprofen, citalopram, and carbamazepine once daily. Her lab findings are listed here as well. So you see that her viral load is 26,000, her CD4 count is 480, her serum creatinine is 0.8, and that calculates to a creatinine clearance of 85 mils per minute. Her AST and ALT are 20 and 11 respectively. She, on her genotype, has no resistance mutations present. Her HLA-B5701 test is negative, and her total cholesterol is 150. So keep Janelle in mind as we go through our discussion today. And what I want to do is really focus on a few key points. The first being antiretroviral initiation strategies, including those factors to consider that are individual characteristics of the patient, as well as the antiretroviral therapies themselves, focusing specifically on co-formulated combination products as single tablet regimens, or STRs. And then we'll follow up a little bit about strategies to help optimize adherence in our patient, and really focus on Janelle's case to make a decision about what we would choose for her. So, keeping in mind, whenever you're thinking about initiating antiretroviral therapy, you have to think about the overall goal. And this is laid out in the DHHS treatment guidelines as choosing a regimen for the patient that is durable and that is going to provide long-term virologic suppression for your patient for many years, if not even decades. Also, very tolerable, safe, and convenient regimen that will allow the patient to achieve and maintain virologic suppression. You also have to think about not only drug characteristics, but first of all, the patient's characteristics. So things like baseline viral load and CD4 count come into play. You also have to look at resistance testing to make sure that the patient, if they have some resistance mutations, that you think about those when you're constructing a regimen. Also, the HLA-B5701 status is important to consider, mainly for a back-of-ear hypersensitivity, since that test primarily helps us to predict that. And if a patient does have HLA-B5701 test being positive, then we would mark them as a back-of-ear allergic.
You know, there's an interesting kind of side note to HLA-B5701, in addition to the very important predictor of this adverse reaction, a back-of-ear hypersensitivity. It also is associated, interestingly, with better HIV control. So people who are, so-called controllers are more likely to be HLA-B5701 positive.
Wow,
yeah.
That's really neat. So you tend to think of that being a negative thing, but in actuality, it's a positive thing.
Reason.
And really, it just restricts a back-of-ear use,
Right.
which is just only one component of the regimen,
Exactly.
of many that you can choose from. Wow, that's interesting. Also, individual patient preferences, I think, are important to consider. So I know that some patients are very bent on only having one pill daily, but I have other patients who are not adverse to taking 2 pills a day,
Right.
or sometimes not even minding twice daily medicine.
Yeah. Now, you mentioned that she's a toll collector,
Yes.
and she works a night shift. So
Yes.
that also obviously play a big role in what kind of medicines you choose.
It definitely does. I think that I threw that into the case because I do have a number of patients in my practice who work off shifts, and they'll work off shifts for a few days and then they attempt to go back to a regular schedule to be with the boyfriend, and so that has to be factored in with what time of the day they're taking their medicines and if they're going to have adherence issues.
And I think you also mentioned the toll collector part because you work in Worcester and live in Sturbridge.
Yes, so I'm paying tolls every day when I go to work, absolutely. And then the anticipated adherence to treatment. You know, a patient who has not taken or who doesn't take any routine medications is going to have a more difficult time working this into their routines versus somebody who, you know, like this particular patient who takes something every day, takes that citalopram every day, that carbamazepine every day. She has a routine with that, and so you have to factor that in when you're thinking about starting therapy, for sure. We also have to look at concomitant conditions that the patient has, and so looking at concomitant disease states that may influence which medication regimen you choose. So underlying cardiovascular disease or risk factors for cardiovascular disease, hyperlipidemia, what their renal and hepatic function are, because these meds are often cleared either one way or the other. Also, concomitant psychiatric illness may make CNS adverse effects of certain regimens more difficult to tolerate, especially in the initiation phase. And then a current or history of drug use, not only because that can impact adherence, but also they may be taking opioid replacement therapy like methadone, which has an interaction with some of the antiretroviral therapies.
Actually, related to what you just mentioned, one of our audience members wrote in which drugs in particular are of concern for psychiatric disorders.
Yeah, so with psychiatric disorders, especially say efavirenz or rilpivirine, those non-nucleoside reverse transcriptase inhibitors are on the alternative list per the treatment guidelines because they do have some CNS adverse effects and tendencies to aggravate some of those issues. And with efavirenz, that tends to be within those first 4 to 6 weeks that the side effects are more pronounced. But for some patients, that may be too much to handle, and you'd want to factor that in.
Yeah, I think it's been interesting over time with efavirenz. You know, when we only had one single tablet option, the tenofovir FTC efavirenz option seemed right for most patients.
Yes.
And then now that we have so many others, it actually seems right for very few patients.
Yes.
You know, it happened really quickly, and it really has to do with integrase options. And as you mentioned, even though there is that acute CNS side effect issue with efavirenz, there's a subset who have long-term side effects, including worsening of depression. And I was involved in a study that showed a 2 to 3-fold increased risk of suicidal ideation in people on efavirenz versus non-efavirenz regimens. So I think that's the one in particular I worry about. I agree that rilpivirine, there's something in the package insert about that too, but not nearly to the degree.
Not nearly as much as efavirenz. I agree. And with efavirenz-based regimens too, you're right, that now that the data is showing that more folks are having adverse effects even far out with it, that it makes it, I know we've switched a lot of patients off of that particular single tablet regimen. So we'll talk about that a little bit later as well, because you'll still see some patients who are taking that, but I think it's definitely important to recognize. Thank you. Also recognizing pregnancy and pregnancy potential. So here comes efavirenz once again. Efavirenz tends to be an issue in somebody who's trying to get pregnant or for that first few weeks of pregnancy, because it can cause neural tube malformations. And so if you have somebody who expresses interest in getting pregnant or, you know, is not practicing safe sex and you're concerned about unintended pregnancy, you would need to avoid that regimen as well. And then considering co-infection of HIV with hepatitis B and hepatitis C, mainly because you'd want to make sure your HIV regimen is covering your hepatitis B regimen or coverage for that viral infection. But also with hepatitis C, there are some drug interactions between antiretrovirals and hepatitis C medications to consider. Then you have your antiretroviral specific considerations that also come into play. So you have to think about the regimen that you choose. Is it going to be durable and give long-term virologic suppression for your patient? Does it have a high genetic barrier to resistance where multiple resistance mutations are required in order to render that antiretroviral ineffective? What is the adverse effect profile? We already started talking a little bit about that and how it factors in with respect to selecting therapy for an individual patient. Drug interactions. You really have to pay close attention to these because they can either increase toxicity for a patient or cause the regimen to be completely ineffective. And so I always encourage people to check for drug interactions. You can use hivdruginteractions.org. That website has a plug and chug that really lets you go ahead and look at the drug interactions much more detail. And when we revisit Janelle's case, we'll talk about those in more depth as well. And then dosing convenience, looking at pill burden. There may be some patients who say, I'm not taking more than 1 pill a day for this, but then others who say, well, I'm already taking 10 other medications. Having 2 pills at once or 3 at once is not necessarily going to bother me. Dosing frequency, many patients prefer once daily, but again, some may not be adverse to twice daily if they're taking other twice daily regimens. And then single tablet regimen availability also comes into play as well, which we'll be talking about. And then I think you'd be remiss if you didn't include cost. Most patients, true, they do have assistance programs and insurances that are paying for these, but there are still some of these agents that require prior authorization or have high copays depending upon what your patient's plan is. So
I think this is one thing that we HIV providers are experiencing more and more every year. Time was that this was sort of protected space and the payers just let us prescribe whatever we want, but now with any introduction of a new HIV option, the treatment option, they typically require some form of prior approval or some form of formulary review. And not surprisingly, since when we're doing this, the recent tenofovir alafenamide formulations are top on that list right now.
Definitely. I think that you have to remember this mainly because it may exclude certain patients from receiving what you want them to receive. Whereas you're right, we used to have carte blanche where you could just say whatever you wanted a patient to receive, that was what you got. Exactly. But nowadays, just thinking about that, and also many plans will also have a 6-month moratorium on new products that get introduced, automatic, where they're reviewing that and considering what prior auth criteria they're going to have, if any, and that excludes any patients from receiving that for the first 6 months under that plan. So great. So now I'd like to review what single tablet regimens are currently available. So I've divided them up into those that are recommended per the DHHS guidelines and those that are alternative. So the recommended ones are the ones that we consider preferred. They're the ones that have the best data in terms of durability, tolerability, convenience, and so that's why they tend to be on that recommended list. So you see the first there, we have dolutegravir with abacavir and lamivudine, and that's known by the brand name Triamec. We also have another integrase inhibitor-based regimen, which is elvitegravir, cobicistat, and tenofovir alafenamide, or TAF, and emtricitabine, known as Genvoya. And then the older formulation of this single tablet regimen contained the same components, but the tenofovir component is tenofovir disoproxyl fumarate, or TDF, instead, and that's known as Stribild. So a couple of factors to consider with this. The cobicistat, why that's included in those elvitegravir regimens, is because that is a pharmacokinetic enhancer, and it inhibits the cytochrome P450, 2D6, and 3A4 isoenzymes in order to boost the concentrations of elvitegravir to make it, to help it to achieve the concentrations it needs to for virologic suppression. We also, when you're thinking about tenofovir alafenamide, or TAF, that one I think of as more of a renal and bone-friendly tenofovir formulation, and is really coming to the forefront because of its increased safety. And you'll see that when we talk about each agent in more depth, that the tenofovir, or the TAF, allows us to dose that drug at a lower creatinine clearance. And so whereas patients who were previously not necessarily candidates for single tablet regimens because of having creatinine clearances around 50, for example, these we're able to go down to 30 mils per minute. So that definitely opens it up a little bit more for patients. We also have alternative regimens available. So we mentioned efavirenz, TDF, and emtricitabine, which is known by the brand name Atripla. We also have rilpivirine with TDF and emtricitabine, known as Complera. And then a newer agent that's available, basically it's looking at that rilpivirine again, but this time formulated with TAF as the tenofovir component and emtricitabine, known by the brand name Odefsey. That one is not yet in the DHHS guidelines, but I would anticipate that it would get incorporated as we go along once a new update is available.
Right, and as I mentioned earlier today, it's quite striking to see this new single tablet regimen, the TAF FTC rilpivirine one, because it is by far the smallest of the single tablet regimens. It has some other issues. You have to take it with food, you have to take it without acid reducing drugs. Rilpivirine isn't the most potent drug we have, but for people who have trouble swallowing pills, it's very useful.
Yeah, and that too, when you're initiating therapy, we talked about pill burden and we talked about some of that, but that is a real consideration for some patients that you have to think about. And I know that even in the days of when the only single tablet regimen we had available was efavirenz, TDF, and emtricitabine, that people would complain it was a horse pill and say, that I'm having difficulty swallowing that. Can you just break it up into individual components for me? So yes, you definitely have to interact with your patient to gain an understanding so that non-adherence doesn't stem from the pill size being too large. All right. So there are some practical aspects to single tablet regimen options that I want to consider. There's obviously a lot of advantages. They were the most straightforward in terms of being, simple, one tablet daily dosing, very convenient for the patient. Also, it provides a single copay for a patient, which again, some patients' plans do have hefty copays, and if we're able to minimize that to one instead of say 2 or 3 copays, that definitely can make a difference. And then another key point, I think, is that it prevents non-adherence to an individual regimen component. And I can't stress that enough, because sometimes you have patients who put their meds in pill boxes and may forget to put one in if they have multiple tablets. But I've also had patients who have inadvertently not picked up all of their meds from the pharmacy and have forgotten their pharmacokinetic booster, like the ritonavir or something like that, and not even realized it until a month later when they picked up their meds and went, oh my God, I forgot that one. Yeah. So I think that that's an advantage that can't be stressed enough too.
Sure. The other thing is it drives patients crazy are on multiple medicines when the refills are on different cycles.
Yes.
And it's very, very hard to get them aligned sometimes, and that obviously is not an issue when you've got just one tablet.
That's a great point too. It's very easy to have them go a little bit off of each other, and then it's very inconvenient for the patient to refill them. And that goes for whether they're filling them monthly at a retail pharmacy or maybe have a mail order pharmacy where they're doing it every 3 months. It's the same difference. Very good. So, but there are some disadvantages. As a pharmacist, the one that I consider is that I really can't adjust the dosing for the individual components because they're all together as a fixed dose. That becomes an issue for when you have patients who are taking a single tablet regimen that contains TDF, for example, because that one needs to be dose adjusted at a creatinine clearance less than 50. It moves to an every other day dosing, but you can't do that when it's co-formulated because it will mess up the other components to the regimen. Cobicistat, we'll see when that's co-formulated with TDF, that also has creatinine clearance restrictions as well. So that's one disadvantage that you may have, but it would only really be a disadvantage for certain subsets of patients. So now let's talk about the nuts and bolts of the individual medications. So we'll first look at dolutegravir, abacavir, and lamivudine. This is an integrase inhibitor-based regimen that has a high genetic barrier to resistance. Dolutegravir is our latest generation of integrase inhibitors and thus has a high genetic barrier to resistance and tends to be somewhat of a forgiving regimen, although we really need to still strongly emphasize adherence to all of these regimens regardless. And it is a recommended option for initial therapy. The special considerations, it does chelate to multivalent cations, the dolutegravir component primarily. And so if a patient is taking, say, antacids or iron or aluminum salts, to make sure to stagger that to prevent that chelation, because that would result in reduced absorption of that dolutegravir component and could compromise the efficacy of the regimen. We already alluded to the fact that abacavir has some issues associated with it. The hypersensitivity reaction that is typically predicted by the HLA-B5701 screening test. Even in somebody who is negative for that test, we still do need to counsel them about that reaction because it can still happen in a subset of patients. And so I still do like to warn patients if they did get a rash or flu-like symptoms after initiation that they need to contact you immediately because they need to discontinue that and never be rechallenged for fear that they would have a fatal hypersensitivity reaction.
I think the biggest issue with abacavir today is the possible association with increased cardiovascular risk.
Definitely.
The data are mixed, but in patients who have cardiovascular disease or who are at high risk for cardiovascular disease, it's just more comfortable to avoid it entirely if possible.
Exactly. I know that that's what we do. We usually we screen them and we'll say, you know, honestly, because of concerns about inflammation with abacavir, with lipid concerns, that we just stay away from that because the potential risk outweighs the benefit, even though data is conflicting.
Exactly. And one other drug interaction, just to mention, that because it came up late after dolutegravir was approved, and that's this metformin drug interaction. There's a maximum daily dose of metformin of 500 milligrams twice a day, or 1,000 milligrams a day. Can't exceed that dose when taking dolutegravir, because dolutegravir significantly increases metformin levels.
Oh, that's a
commonly
great
used drug.
point. Very commonly used, especially because that's first line in our diabetes guidelines.
Exactly.
So
I'm always happy when I can say a drug interaction to a PharmD.
And I get all excited about it.
Exactly.
I do. And especially when it's something so common and very clinically relevant like that, because some of the drug interactions that you see with these agents, you may say, I never use that drug, but metformin, you know, that's definitely coming up a lot. And then also, again, the rigidity of a single tablet regimen for when you have a drug that's renally cleared, like lamivudine, that requires dose adjustment. Once you get below creatinine clearance of less than 50, you would have to break out the individual components and use them individually so that you could dose adjust that lamivudine accordingly. Moving on to elvitegravir and cobicistat and with TAF and emtricitabine. This is also an integrase inhibitor-based regimen. Again, some special considerations to think about is with that cobicistat being a pharmacokinetic enhancer, you are inhibiting the cytochrome P450 system, especially 3A4, which can be problematic because that's the system that's responsible for metabolizing 90% of drugs that go through your liver. And so as a result, you've got to check your references very carefully. True, it's a cleaner pharmacokinetic enhancer than ritonavir because it inhibits fewer cytochrome P450 enzymes. You still have to be concerned about it for sure and check those references carefully. We also have to be aware that lipid elevations can occur with cobicistat, so we keep an eye on that. But the neat thing about it is that it can be used in creatinine clearance greater than 30, and that's primarily because of the TAF component being the tenofovir that is utilized, that formulation of tenofovir. And that's in contrast to elvitegravir when it's combined with tenofovir disoproxil, so TDF and emtricitabine. And you'll see listed there that you need to avoid initiating it in patients who have creatinine clearance less than 70. And that's because of that interaction with the CoB and the TDF, but also it needs to be discontinued in patients with creatinine clearances less than 50 because of, again, the TDF and the emtricitabine needing to be dose adjusted. So it makes it very tricky because that's a pretty narrow window you're working with, and a lot of my patients tend to hover around this area anyway. A lot of them will hover even somewhere around 60, 55, making that a little bit trickier. So I could see that this agent would be less preferable as compared to the formulation of elvitegravir with TAF.
Yeah, the TAF one seems like it should replace this one, but the actual removal of medications from the stores is a tricky process. So they're both still available, but I can't imagine using the TDF one anymore unless the patient's insurance doesn't cover the TAF one.
I know, and I know that when the TAF one came out, we started utilizing that. We really shied away from initiating anybody on the TDF formulation. So, and the ironic thing too is when you look at the cost, the average wholesale cost of this particular product here is actually it's the most expensive one. And so the TAF formulated one is less expensive. So. Then looking at some of the alternative agents, such as efavirenz, tenofovir, or TDF rather, and emtricitabine, we already alluded to the fact that it has some issues with adverse effect profile, but a few other issues with non-nucleoside reverse transcriptase inhibitor-based therapy is that they do have more drug interactions associated with their use, because efavirenz is especially tricky. It's a 3A4 substrate, but it's also a 3A4 inducer and an inhibitor. So it makes the interactions a little bit more difficult to predict.
Unpredictable, exactly.
They really are.
So your patients on statins, for example, can get into trouble with the cobicistat, meaning the statins go up.
Yes.
And with the efavirenz, because the statins go down.
Exactly.
So it's tough.
It really is a challenge. And then add to that efavirenz should be dosed at bedtime because of the central nervous system adverse effects, that it needs to be on an empty stomach, which is another reason for doing it at bedtime. The pregnancy issues we already alluded to. So it does have more issues associated with it, hence why it's not on the recommended list and why it's on the alternative list. We also have rilpivirine, which is a non-nucleoside-based regimen as well, co-formulated with TDF and emtricitabine. This, too, need to check for resistance mutations in advance of starting it, because it tends to have a lower genetic barrier to resistance than integrase inhibitor-based regimens. But also this one in its product labeling notes that we should avoid it in patients with pretreatment viral loads of greater than 100,000 or CD4 counts less than 200, that those patients tended not to respond as well as the comparator regimens in clinical trials. And so that's something that you need to screen for. Obviously, you're going to get a viral load and CD4 count in advance of initiating therapy. But this too, once again, drug interactions associated with its use. It has all of those 3A4 issues associated with it, but then on top of that, it also has acid suppressor issues too, because it needs an acidic GI tract for optimal dissolution of the drug. And otherwise, you're going to impact that and potentially promote virologic failure. Recently, rilpivirine was a new formulation came out with TAF and emtricitabine, and this one is not yet in the guidelines because it is so new, but the considerations for its use are very similar to that with which we saw with the TDF formulation. Although, again, I think that this one will probably supersede that in the future, just because you can use it at a lower renal function cutoff than you can with the TDF formulation. So now I just wanted to take a brief look at some study data, just to take a look at the fact that using single tablet regimens, whether they're being compared against other STRs or multiple tablet regimens, are quite effective. And so looking at studies 102 and 103, this was basically looking at the co-formulation of elvitegravir, cobicistat, and TDF and FTC as compared to efavirenz and TDF and FTC daily. That was study 102. And then that same regimen was compared against a boosted atazanavir regimen with tenofovir and emtricitabine as the dual nucleoside backbone. And so patients, to qualify for this study, they had to have viral loads of at least 5,000, any T cell count, and their genotype had to show susceptibility to all of the possible regimens. And they were randomized in a one-to-one fashion to these regimens. And so looking at the results of study 102, basically the bottom line was that the co-formulation of elvitegravir with cobicistat and TDF and FTC was not inferior to the efavirenz-based regimen. And so that was seen as early as week 48, but all the way out to 144 weeks. Virologic failure rates were similar, and discontinuations due to adverse effects were quite similar as well. Looking at the results of study 103, again, that co-formulation of elvitegravir was non-inferior to the boosted atazanavir regimen in treatment-naive patients. Again, at all time points, we saw that. And also with virologic failure and discontinuations due to adverse effects were very similar across the board as well. Dolutegravir was also studied against a number of different regimens as well. And so dolutegravir in this case was not co-formulated. It wasn't available co-formulated at that time, so it was given with the abacavir and lamivudine as two separate tablets. But it was also compared against the efavirenz-based regimen, and then that was in the single trial. It was compared against boosted boosted darunavir, with 2 nucleoside reverse transcriptase inhibitors of the investigator's choice. And it was also compared against another earlier generation integrase inhibitor, raltegravir, with dual nucleoside backbone of choice as well. So we're going to focus on the results of the single study for a moment. And this is, again, comparing the dolutegravir-based regimen with the efavirenz-based regimen in treatment-naive patients. So again, what we actually saw was that non-inferiority was met, but actually the dolutegravir with the abacavir and lamivudine was superior to the efavirenz-based regimen at week 48, 96, and 144. And the reason for that was primarily due to the fact that there were more discontinuations in the efavirenz-based regimen, and as a result, there was less virologic data to assess. And so that's just very telling to say that those adverse effects of the efavirenz-based regimen do continue out even beyond that initial 4 to 6 weeks where the worst of the nightmares and dizziness surpass, but that maybe some of those depressive issues also are coming out later on. So now I kind of wanted to bring us back to Janelle, because we've talked about a lot of different concepts and some study data, but now we have to think about what antiretroviral therapy we want to initiate for Janelle. So I think if you go back and kind of think about her, obviously a single tablet regimen would be ideal for a patient who is young, who is otherwise just taking once daily medicines routinely, like the citalopram and the carbamazepine. That would be really ideal for this particular patient. So before thinking about what you would choose, I think you have to step back and say, all right, what is her viral load? She has no resistance mutations, no known allergies. Her renal function is great, no cardiac risk factors. She works the night shift as a toll collector, which when we talk about facilitating adherence, we have to bring that back to the forefront. And we also have to think about her concomitant medications, which when I look at her medication list, that carbamazepine sticks out like a sore thumb, because that is a very potent cytochrome P450 enzyme inducer that really wreaks havoc on our antiretroviral regimens. And as a result, I think that it's really important to say, all right, that carbamazepine, could we utilize something different here? And so I know that in my practice, I very frequently will contact primary care providers to see if there's something alternative that we could use instead. Because regardless of if we're looking at single tablet regimens or multiple tablet regimens, that carbamazepine is going to wreak havoc. And so since she's using that for a combination of migraine, headache, and seizure disorder, perhaps we could recommend using something that has less of an interaction potential but would still have good efficacy, like a topiramate, for example, which does not have interactions with the antiretrovirals we're considering. And so really that carbamazepine is pretty much contraindicated with just about all of the antiretrovirals we're looking at. The only exception here is the dolutegravir can be used with carbamazepine, but it has to be dosed as twice daily, not once daily, which would get you away from using a single tablet regimen. So the obvious choice here to me would be to say that carbamazepine is a little archaic and is wreaking havoc, so maybe we could change that to something else. And if we are able to do that and get that changed, then it opens up a world of possibilities for her. You know, we could look at the dolutegravir-based single tablet regimen for her, because she's HLA-B5701 negative, she has no cardiac risk factors, and she has no resistance mutations, so that could be an option. Again, our other integrase inhibitor-based, the elvategravir-based regimens, those could be an option for her as well. Again, it might come down to prior authorization, or which ones she could be a candidate for. The alternative regimens, I don't feel that we necessarily need to look at for Janelle. She does have depression, so I'd probably steer away from the non-nucleoside-based single tablet regimens. But if you had some issue that would prevent you from those recommended ones, then perhaps you might look towards the alternative ones. But I think in this case, if we could just get rid of that carbamazepine, that we would have an opportunity to utilize some of the recommended single tablet regimens. but also facilitating adherence to antiretrovirals for Janelle. I think that that's a very important concept to talk about for her, primarily because she does work a night shift, and you want to kind of gauge on those 2 days that you're not working, are you flipping your routine around? Because I'd really like her to take her medication at the same time each day so that we can keep consistent concentrations and also keep it as part of her routine. Anytime something switches in the routine, that's a risk for missing a dose, and we certainly don't want to have that happen. So recommending to her, you know, alarms as appropriate. I know a lot of my patients now use very fancy apps and reminder systems until they get it more into their routine where it becomes second nature. I think that those are important.
So, I mean, one thing to consider also, and it's related to one of the questions we got from the audience, is whether the 2-pill regimen of TAF-FTC plus dolutegravir should be considered. Even though it's not a single tablet regimen, it does still include one co-formulation, and it gets rid of some of the Abacavir issues. You know, I think many of us think that would be our best combination if it were co-formulated, although it's not going to be. One of the questions is, are you concerned about that combination because there's no clinical trials data? And I guess I'm not, because TAF-FTC and TDF-FTC have been really identical virologically in all the various studies.
Absolutely, and even before the TAF-emtricitabine combination came out, we were using, and we still do use, TDF-emtricitabine with the dolutegravir a lot. Exactly. I mean, I have a lot of people who are on that because, again, many patients are not necessarily concerned about taking 1 versus 2 tablets. But if you have somebody, I do have patients who say, no way, I don't take anything else, it's got to be a single tablet regimen, then you can gear it towards that.
But I like your idea of getting rid of the carbamazepine. As soon as I saw it on the list, I thought, that's got to go.
Yes, exactly. That's why communicating with, with the primary care provider is very, very helpful, because we're able to make adjustments. And there's a lot of things that they may say, you know what, they were on that before I even had them. And come to think of it, I'd really like to change that.
Okay, great. Thank you very much, Linda. I'm going to now go on and talk about a different kind of case. And it's basically treatment simplification in treatment experienced patients. Is a very complicated topic, and one that really kind of pushes the HIV specialist sometimes. In this case, will be no exception. So this is a 48-year-old man. He's Alan. He was diagnosed HIV positive in the early 2000s, and he also had secondary syphilis at the time. He had a CD4 cell count over 500, and as was typical then, he wasn't treated, even though his viral load was 93,000. And he didn't get started on treatment until 2003, when he entered a clinical trial that actually turned out to be something of a disaster. It was a study that looked at tenofovir versus efavirenz given in combination with abacavir and lamivudine. And we didn't know this at the time. Those were all, theoretically good drugs to combine. But it turns out that the abacavir, lamivudine plus tenofovir arm, as you'll see, didn't work very well, and that's what he was randomized to. So he went on this treatment. He took his medications exactly as directed, but he ended up having virologic rebound to 70,000 by week 4. And when he was approached, he said, no, I'm taking my medicines. I'm good at taking medicines. And they found that he had resistance. He developed resistance with the M184V mutation, that's resistant to lamivudine, and the K65R mutation, that's resistant to tenofovir, and that together was interpreted as giving him resistance to all the nucleoside analogs with the exception of zidovudine. And that study ended up being terminated early because of excess virologic failures, and we learned something about the combination of nucleosides, that not all combinations can be given willy-nilly, and as you'll see at the top is the efavirenz arm of the study, and at the bottom is the tenofovir arm of the study, and the people at the bottom, the viral load trajectories don't look right. They go down and then they bounce right back up, and that's what happened to this guy. But the question is, what happens after the study, which is sort of interesting. He got put on a new regimen. The new regimen was lopinavir, ritonavir twice daily, efavirenz once daily, and zidovudine, lamivudine twice daily. So this is a tough regimen to take, but virologically is terrific. He's getting a new drug class with the efavirenz. He's getting a new drug class with the lopinavir, ritonavir. He's getting active nucleoside with the zidovudine. And some people say the 3TC lamivudine gives you still some antiviral activity, even with the 184V mutation. And not surprisingly, virologically suppressed very quickly. CD4 cell count increased to greater than 500. And he lived happily ever after. No, not the case. He ended up developing hyperlipidemia and was placed on atorvastatin and diarrhea, which is probably from the lopinavir ritonavir, but he's been able to continue treatment, and he does not want to change. And he doesn't want to change because he's already been on one regimen that failed, and this one is controlling the virus. It's working so well, why should we change? So now I'm going to ask our audience to vote, and I'll also ask you in a moment, would you encourage him to change this regimen? Your options are nope, the treatment's working, and he's reluctant to change. Yes, but I wouldn't push it. I'd kind of let him decide. Or yes, I would strongly encourage him to change. And I don't know if you encounter patients like this, people on these antiquated regimens, but they don't always want to change their therapy, even though we might think it's the best thing for them. And sometimes they stick to them. I think every practice has a patient or two still on indinavir or nelfinavir.
Yes,
yeah, so
we do. We have one who is on lamivudine, zidavidine, and nelfinavir. And you're right. It's that they don't want to rock the boat. They just want to, and they'll say, no, I just don't want to change.
Yeah.
So as your patient is describing.
Yeah, I mean, it turns out that our audience has overwhelmingly voted for C, that they would strongly encourage, and I certainly agree with them. Because this regimen is not a good one for long-term health. So anyway, bunch of reasons to consider switching, and I've listed them here. This is from the DHHS guidelines. You can improve adherence, reduce pill burden. That's especially important in this case. When this patient first started this regimen, he actually had to increase the lopinavir dose because of the efavirenz. He was taking 4 lopinavirs twice a day, efavirenz before bed, and 2 zidovudine lamivudines twice a day. Anyway, all kinds of problems with it. Other things, the side effects, he's gotten both a short-term side effect with the diarrhea and a long-term, short and long-term, the diarrhea and the hyperlipidemia. Improved tolerability, food requirements can be tricky, drug-drug interactions, many with this regimen, as you know very well, and sometimes reduce costs and improve quality of life. So when you look at the guidelines on management of patients who are virologically suppressed, they have this message. The message is the cardinal principle of regimen switching is to maintain virologic suppression without jeopardizing future treatment options. It's critical to review a patient's full antiviral history, including virologic responses, resistant test results, and past adverse events before any treatment switch. And so we see this, and we've reviewed his treatment history. Well, what guidance can we get from clinical trials? Now, there are a lot of switch studies out there, and the key thing about most switch studies is that they are, by and large, done in patients without a history of treatment failure or resistance. So let me give you some examples. There's the SPIRIT studies of switching people from boosted PIs to rilpivirine-based regimens. There's the strategy PI and strategy NNRTI, switching people from PIs or NNRTIs to co-formulated alvategravir, cobicistat, TDF-FTC. There's the striving study, which switches people to abacavir, lamivudine, dolutegravir. And also there are now plenty of studies switching to TAF-based regimens. And they all show that in this patient population who have never failed, that you can switch them and they do really well. And that's really not that surprising because they've already demonstrated that they can take their medicines, they're virologically suppressed, and they've never failed. And you can switch them and they do fine. Not applicable to our patient. Our patient has failed, he has resistance. There are a few exceptions. There are a couple of switch studies out there that do look at people who have failed previously. Probably the most important historically is the Switch-Merck study. The Switch-Merck study took patients doing well on their lopinavir-ritonavir-based regimens, virologically suppressed, and then randomized them in double-blind fashion to either to continue the lopinavir-ritonavir or to switch it to raltegravir. And you could imagine that when this study was being designed, you looked at these two drugs. Raltegravir is better tolerated, just as potent as lopinavir-ritonavir. You'd imagine that this would work, that raltegravir would be better than lopinavir-ritonavir, even though the patients were tolerating lopinavir-ritonavir fine. It turns out, though, a key issue with this study was that they enrolled people who had had a prior history of treatment failure and/or resistance. And so when we look at our results in this slide, you could see that overall, the switch people did fine. If you look at the people who've never failed, or lopinavir-ritonavir is their first regimen. But if you look at the people who did fail, or who had not lopinavir-ritonavir as their first regimen, then the lopinavir-ritonavir was better. And that's probably explained by the resistance that they had archived to the nucleoside analogs. And so that has led to this principle that when you're switching people off a boosted protease inhibitor, you have to be very careful. So the guidelines say switching from a ritonavir-boosted PI to a regimen composed of drugs with a lower barrier to resistance generally maintains viral suppression, provided there's no resistance to the other components of the regimen. Of course, in this study, we do have resistance. However, such switches should be avoided if there is any doubt about the activity of the other agents in the regimen. So we're left in this guy what to do. Can we learn something from other studies? Well, recently at ID Week, a very interesting study was presented, and it looked at people who've had treatment failure but are currently virologically suppressed, right? To get into the study, they had to be taking a darunavir-based regimen and not have more than 3 thymidine-associated mutations and not have any resistance to integrase inhibitors. And then they could be randomized to either get the 2-pill regimen of ECF-TAF, that's the new version of Stribild or Genvoya, plus darunavir, 2 pills a day, or to stay on their baseline regimen. So what you're essentially doing is you're allowing people in who have failed before with some nucleoside resistance, but not the most extreme. They couldn't have Q151 mutations or 69 insertions or more than 3 TAMs. And the results were very impressive. It showed that the switch was actually, at week 48, superior to staying on the present regimen because many of the patients had a much simpler regimen than they had before. You can see 94% success versus 76% success. It was an open label study. I think a lot of people who were randomized to continue were disappointed and maybe they dropped out for that reason. But it was very, very encouraging. And I think it does give us providers license to change some of these older, cumbersome regimens. So the key message, switching people who have a history of treatment failure is in fact doable. And you can switch from a complex regimen to one that is new and simpler, provided the regimen consists of at least 2 active drugs. And such a strategy requires that we know the full treatment history. So what can we learn about patients who've been studied who've had treatment failure? Maybe they're not directly applicable to this case, but they should be relevant. And several studies have looked at second-line treatment in people who failed a 2-nucleoside plus non-nuke-based regimen. And then what do they do next? There's the EARNEST study, the second-line study, more recently ACTG 5273. They basically are looking at recycling the nucleosides plus the boosted PI, or they're looking at the boosted PI plus an integrase. And they all have shown that the boosted PI plus recycled nucleosides is just as good as introducing this next drug class. And so that shows the nucleosides are still providing a lot of activity and the boosted PI has a lot of resistance barrier. So what we can infer from this is that people who are already suppressed can probably be managed with the same strategies, because people who are already suppressed are easier to treat than people who've had virologic failure. So let me just show you the most recent example. This is a very typical study. These are people who failed a 2-nuke plus non-nuke-based regimen, and then were randomized to lopinavir-ritonavir plus raltegravir, or lopinavir-ritonavir plus best available nucleosides, which often meant that, if they previously were receiving AZT, zidovudine, they then went on tenofovir or vice versa, so it wasn't always done with genotyping. And this is the result, and this is similar for the EARNEST and second-line studies. Time to virologic failure, very similar between the 2 arms. So recycled nucleosides are just as good as raltegravir plus a boosted PI in second-line therapy. This is another one of those studies. This is the resistance analysis. It's sort of paradoxical. If you look along the horizontal axis, this is the number of active nucleoside reverse transcriptase inhibitors. And you'll notice that if the patients had 0 active nucleosides, they had the highest treatment success. And that's actually a paradoxical effect that's been seen in multiple studies. And it has to do with the fact that these describe the patients who've been pretty adherent to their failing regimen. The people with no active nucleosides were actually pretty non-compliant with their failing regimen. So this is a proxy for adherence. So if someone's put on, for example, a zidovudine, lamivudine, nevirapine regimen in a resource-limited setting and fails virologically and continues to take their drug very faithfully, they'll get more and more resistance. But that person who takes their medicines faithfully, when put on a good regimen, they actually do quite well. And that explains this result. It's an adherence proxy. One other thing to mention is dolutegravir has been studied in treatment-experienced patients also. And this is the SAILING study. And patients who have failed regimen were then put on either dolutegravir-based treatment or raltegravir-based treatment. plus background regimens selected by the investigators. And this sub-analysis, which hasn't been published yet, actually looked at those patients who were managed just with nucleoside analogs, plus either dolutegravir or raltegravir. And what it showed is that the patients who got randomized to dolutegravir did not have any virologic failure, versus 7 out of 32 of the patients who were randomized to raltegravir. This is further evidence of the high genetic barrier to resistance in dolutegravir. And if you notice in particular, the group who have 184V, 0 out of 13 failed versus 4 out of 12 with raltegravir. So I think that if the switch-merc study had been done with dolutegravir, it probably would have worked, but wasn't available at the time. However, our patient has 184V and K65R. So that's not the same thing as shown in this study. I am sure there were patients like that in sailing, but we don't have all the data. So we share the data with Alan about this, the safety of switching. We say to him, we really think you should switch. You're getting hyperlipidemia and diarrhea from your regimen, and he agrees. But he wants you to choose what the best option is. And so you give him several 2-pill options, and I'm going to list them all on this slide, plus a wild card. And they could be TAF, FDC, plus darunavir cobicistat. So that's the kind of recycling nucleosides plus boosted PI. You could give him TAF, FDC, plus dolutegravir, like in the sailing study. You can give him ECF, TAF, plus darunavir, like in the study presented at ID Week this year. Or you could give them something without a protease inhibitor at all. This is TAF, FDC, rilpivirine, plus dolutegravir. This regimen has not been studied very much, but if you count the number of active drugs, you've got active dolutegravir, active rilpivirine, and partially active TAF, FTC. Or you can give them something else entirely, and I don't know what that would be. And our audience is now going to vote from this, and I don't think there's really necessarily a right answer here. Yeah, and they are all kind of asking you to choose the art of medicine really more than go to the textbooks and find the absolute right choice. But it is amazing that we can now treat someone like this with just 2 pills, isn't it?
Yeah, it really is. And this would be one where we would bring it to a division meeting and have a debate about it. And I could envision a few of us having different opinions on which one we feel is more correct. So you're right. I think, as my chief of ID says, it's there's more than one way to skin a cat, so to speak.
Definitely. So the majority have answered A. So the majority are using the boosted protease inhibitor plus the TAF-FTC combination, and that is very much like what these second-line studies tell us is safe to do. I mean, it does simplify things enormously. He's taking a boosted PI, only a bad old one, and he's taking nucleosides, only bad old nucleosides. So this is very, very consistent. I think all of these are defensible in some way, but I think the audience made a good choice. So the 2-pill regimen of TAF, FDC, darunavir cobicistat was recommended, and he was informed that his lipids would probably get better. His GI side effects would definitely get better. And then if they didn't get better, I feel comfortable enough with the TAF, FTC, rilpivirine plus dolutegravir, although it does get us out of the boosted PI world, which is a little concerning because of the barrier to resistance issue. The other thing I told him is that there's a TAF, FTC, darunavir cobicistat single pill in development, and that one day he might be able to switch to that. He did very well on this regimen. He's doing fine. And not surprisingly, he's been virologically suppressed for years. The virologic suppression is maintained. So it's a happy ending. I want to conclude this particular section by saying that given the improvements in treatments and novel co-formulations that we have, even patients with prior treatment failure and resistance are candidates for treatment simplification, especially if they have some degree of toxicity from the regimen. Safe switches in therapy must consider the entire treatment history to make sure that they maintain virologic suppression. Do you have any questions yourself about the case? Or?
No, I think you're right about getting that accurate history. I know that the challenge for us a lot of times is that if we have a patient who has had care at multiple institutions, trying to piece that history together can really be difficult. So, but it's worth going to those lengths of contacting the other providers, trying to get those records, because sometimes they can be old.
Oh yeah, exactly. And actually one of the big stressors to the system back when they were first introduced was genotype reports. So that was right at the point where a lot of people were transitioning to electronic medical records, and genotype reports very poorly integrated into medical records.
Yes.
Very, very poorly.
I agree.
So every so often I'll go back and someone will have had a genotype done in the late 90s, and all that's listed in the electronic medical record are their interpretations without the actual mutations, and that's really frustrating.
Yes.
Because we
Oh my
know
gosh.
that the mutations and the interpretation of what the mutations mean has changed dramatically since then. So
you need that initial,
you need that,
yeah.
the actual piece of
I
paper.
hear you,
Yeah,
totally.
yeah. For example, I
Yes.
mean, stavudine and zidovudine were not felt to be cross-resistant initially. So you would see patients and they would say resistance to zidovudine but sensitive to stavudine. Well, we know that really basically
that's
can't
not
happen.
true.
So that was very frustrating. So I have a question here which is very relevant to this, this case. It says, I have a patient who has been stable for years on boosted atazanavir and Truvada. He failed treatment in the past with Atripla and has the K103N mutation. That gives you resistance to efavirenz. Does he have any options for a single tablet regimen? So that's the question. So
Yeah, let's think.
Well,
yeah.
clearly not Atripla.
Yeah, clearly not Atripla.
Yeah.
I wonder, I mean, dolutegravir, bacavir, lamivudine.
Yeah, I think that one would work. And I also think the one with elvitegravir, cobicistat, FTC, TAF would work. And
Sure.
I think that here I'm just going to throw something tricky into the mix. There are people who are worried that people who fail therapy, that they fail it and then they fail it by stopping their treatment, and you might detect the K103N because it doesn't impair fitness, but the 184V goes away. You can no longer detect it, but it's archived. So if you think the patient still has resistance to lamivudine, it might be best to go with the TAF FTC, elvitegravir, cobicistat option.
You're right.
But if you don't, then I would think either one would be fine.
I could see that.
And you're kind of playing off the better activity of TAF with 184V on the one hand with one regimen, with the better resistance barrier of dolutegravir on the other.
Yeah,
So
it's a balance.
it's a balance.
yeah.
I'm not sure which one
sure.
I would choose. Here's one for you, okay?
Okay.
So what statins can you use in patients who are taking cobicistat or ritonavir, and which statins should you avoid?
Oh, good question. Yes. So statins are a little tricky. So some of the older ones, so lovastatin, simvastatin, definitely out. I mean, those are out. Atorvastatin, usually the dosing of that just has to be lower. So you're looking at doing a 10 and maxing it out at 20. And sometimes patients will get freaked out by that, and I'll say, well, you know, a 20 milligram Atorva in you taking one of these enzyme inhibitors is really equal to about a 40 to 80 milligram dose. I do like using pravastatin a lot. That's one of the more traditional ones that it gets metabolized outside of 3A4, and so that's always been a go-to one for HIV providers. The only challenge with it is that sometimes it's not potent enough. Even when you max that one out, that people still are having issues, so causing you to go to an Atorva.
And it interacts with darunavir.
Yes.
Through a different mechanism.
Yeah,
So-
yes, and that's true too. So that becomes an issue. So I usually will err on the side of, a lot of people will use Atorva, especially because of it being generic and getting away with a very low dose and still having good efficacy out of that.
I
Is that what
agree.
you do?
Once atorvastatin became generic, it made our lives much easier.
Definitely.
Because low-dose atorvastatin with ritonavir cobicistat seems to be pretty well tolerated.
I haven't had any issues with CPK elevations in those patients, or muscle aches and pains, really, even as long as you're using it at low dose.
One other statin to mention, I'm going to mention it for two reasons. One, because it's just not well known, is pitavastatin.
Yes.
Yeah, pitavastatin
Yes.
doesn't interact with any of the HIV drugs. And I'm also mentioning it because we're doing this large clinical trial of putting people with HIV who are otherwise would not be going on statins on pitavastatin to see if we can reduce cardiovascular events, because there's some evidence that people with HIV are at higher risk for cardiovascular disease, and that's deliberately that study chose pitavastatin.
That's great, because that would be a great niche for that, because also to have some clinical endpoints of that, you know, and the drug interaction issue. Wow.
Exactly.
Excellent.
One more question, and I think then we'll wrap up. It says, which HIV drugs are most strongly associated with lipodystrophy?
So lipodystrophy, really those tend to be the older nucleoside reverse transcriptase inhibitors. So I mean that was really a big issue. And then older protease inhibitors too were also linked to it. But I know that nowadays we don't see it nearly as much because of our using tenofovir and emtricitabine as our dual nucleoside backbone, or one of the major ones.
Or Bacavir.
Or Bacavir lamivudine
they
too.
They don't have the same mitochondrial toxicity.
Yeah, the mitochondrial toxicity. I mean, the same goes for, those newer regimens are much less likely to cause lactic acidosis than when we were using stabudine and zidovudine and those older agents.
One thing that is important for us to recognize, though, is that even though lipoatrophy is no longer really much of an issue because we don't use those mitochondrial toxic drugs, fat gain still is. And it's a very complex problem and a difficult one to address because obviously some of the fat gain is people just returning to health, but some of it is non-physiologic. And our patients are blaming the medicines and say, I want to come off, switch me to something that doesn't cause fat gain. But the reality is that any HIV treatment is going to lead to weight gain. And so sometimes I warn people about that. Okay, so thank you. Thank you, Dr. Spooner, and thanks to our audience for the great questions. I would also like to thank ViiV for their support of this important educational activity. Please remember to complete the post-test at the end of the session to secure your CME credits. Please visit ID Care Live to view today's session along with other infectious disease sessions on demand. My name is Dr. Paul Sachs. Thank you for joining us today.